Life is a never-ending journey with a road laid with challenges and hurdles. Though we cannot choose the music it plays for us, but we can choose how we dance to it. Every passing sunset gives us a day less to live, but every sunrise gives us a day more to hope. So live life as if it's just begun. Welcome, ladies and gentlemen, to Dr. Tapaswini's Corner, and that's me, and I work as a head and neck cancer surgeon. Head and neck cancers, one of the most common cancers in India, poses unique challenges in terms of diagnosis, treatment, and rehabilitation. Being the most visible part of the body, the focus of the treatment has undergone a complete shift. To throw light on the various issues pertaining to the disease, we have with us our expert today, Dr. Alok Thakar. You are currently Professor and Head of the Department of Otolaryngology and Head and Neck Surgery at the All India Institute of Medical Sciences, New Delhi, which is one of the premier institutes in India. Your special areas of interest have been neurotology, skull-base surgery, and head and neck oncology. With more than 3 decades of experience in this field, you have held prestigious positions with numerous national and international bodies. Your contributions to this specialty has been honored with various fellowships and awards. Shakuntala Amichand Award, the NES Gold Medal, Commonwealth Fellowship to UK, UICC International Cancer Technology Transfer Fellowship, to name a few. With more than 100 publications in index journals, your research and teaching faculties have been highly appreciated all across the world. Welcome, Dr. Alok, to the program. Really feel honored to have you on the show today.
Thank you, Dr. Tapaswini. Quite a pleasure to be with you.
So let's begin with the statistics. What are the world statistics of head and neck cancer vis-a-vis India?
Cancer has been rising all over the world and is expected to rise with time. At the moment, it is estimated that we have 19 million cancer patients per year, new cancer patients per year. 5% of this is supposed to be head and neck cancer.
All right.
The situation is a bit different in India. In India, oral cancer alone, mouth cancer alone, accounts for about 25% of cancers, new cancers. And this is a problem more in males, both in males and females, but particularly in males, that head and neck cancer, and particularly one of the head and neck cancers, that is oral cancer, has just increased and increased and increased over the years.
But then why is there a large geographical difference in the incidence of these cancers and also in the various primary subsites in the head and neck area? Is that something to do with our cultural habits, or does it have some genetic or ethnic correlation?
So we tend to believe that cancer is a question of misfortune and something that is a bolt from the blue. But that's not quite the way it works. Cancer, unfortunately, is something that often is a result of the way we have lived life over the last many, many years. It takes years and years to have the damage in different parts of the body, which ultimately culminate in a cancer. That is the usual situation. Okay. Or should we say environmental causes of cancer. Of course, there are the odd, unfortunate people wherein they are genetically predisposed to these things, or already come with a few of the damages that are required for a cancer to become. But generally, you need a lot of damage before cancer actually sets in. What we call is a multi-hit or a multi-damage, or what in science terms we call as the Knutson's multi-hit hypothesis.
Okay.
So what tends to happen here is that it depends on how you have been damaging yourself. And unfortunately, a lot of people here in this country use tobacco, and that tends to damage the mouth, and oral tobacco tends to damage the mouth and lead to oral cancer. Of course, we can do smoking, we can do BD, and these also damage the pharynx or the larynx or the throat, so to say. And so different areas, different kinds of things damage different areas, and we get some differences. Within India, there are areas wherein you have more alcohol or wherein people tend to smoke more. The Northeast has a particularly high issue with alcohol and smoking, and there you get more of pharyngeal cancers. So depending on how we damage ourselves, we get some differences.
Right. So how true is this that this disease is more prevalent in the lower socioeconomic strata?
It is actually prevalent in all strata, so to say. But yes, tobacco intake is more in rural and lower socioeconomic strata, so to say, because I think education does lead to some protection from tobacco intake, and that is the probable cause as to why you see it a little bit more in the lower socioeconomic strata. But
so the probable causes of its rising incidence in the Indian scenario, the head and neck cancer is rising. What do you think would be the contributory factors?
So not only has there been a rise, there has also been a change in the distribution of head and neck cancers. If I look back at my career itself, 30 years ago, as you said, we used to see a lot of throat cancer or voice box cancer, or what we call as larynx cancer, which was more smoking related. But as we transitioned from smoking to oral tobacco, and there are many reasons for this transition, the transition occurred because suddenly we found oral tobacco becoming available in pouches, which could be carried in your pocket, and consumption for oral tobacco just increased phenomenally. Also, we had a lot of emphasis on anti-smoking. So tobacco programs have generally focused on smoking, but they haven't quite focused on overall tobacco. So as smoking in public spaces became not allowed or frowned upon, then people sort of transitioned to oral tobacco. And today, as we transition from smoking tobacco to smokeless tobacco, not only do we see that larynx cancer or voice cancer becomes less, but oral cancer starts to become more and more.
Right. But it's quite ironic. I mean, this is an area which is so amenable to visual inspection, but we find a major chunk of our patients come in a very advanced stage. What would you say could be the contributory factors?
So you need to put yourself in the shoes of someone who has been having regular injury to the mouth or to the voice box, and then you would realize that these people are used to having regular ulcers in their mouth because they've been having tobacco, or these people are used to having hoarseness because they've been having smoking, and so naturally they don't tend to take these symptoms as very seriously. And there can be some delay to that aspect. There is also delay because there is, of course, some difficulty with accessing medical care in our scenario, and there can be delay on that side. And also psychologically, I think many of us, and patients particularly, tend to go in denial. Everybody is aware that there is a risk, but everybody wants to hide away from the risk that they face. So if you look at the psychological issues that patients face, if you look at the fact that they are frequently having minor symptoms and ailments in the upper aerodigestive tract because of their smoking or because of their tobacco, you put it all together and we still get delayed diagnosis.
And even ignorance, I would feel, as we said, emphasize that a lot of lower socioeconomic strata tends to have these cancers. Ignorance, they probably don't know that this could mean a disease like this. As you said, Dr. Thakur, you pointed out tobacco, alcohol, sharp dentition. What are the other causative factors of head and neck cancers?
So one thing we didn't quite allude to was, of course, supari or pan masala or condiments, or what we call as betel nut, supari or betel nut. So betel nut itself is a carcinogen. And yes, even if someone doesn't quite have tobacco but is regularly using supari or betel nut, that can cause a problem in your mouth. There
What
are
about?
other head and neck cancers. There are other head and neck cancers which are not so much tobacco related, and cancers of the nose or cancers of the nasopharynx, which are not quite tobacco related, but which may relate to exposure to paints, exposure to chemicals. And then there is the cancer of the oropharynx, which in the West is now very widely related to virus infection, a specific virus which we call an HPV, a human papilloma virus infection.
Okay.
It's not quite very dramatically prevalent in our society yet, but it may occur because HPV infection is a major cause of cervical cancer in our country. HPV infection can actually spread by sexual interactions. And of course,
Right. Are there certain occupations which also predispose them to certain cancers, as you said?
so when it comes to nasal cancers,
Right.
it has been that people who have been carpenters are exposed to certain kinds of wood. And then there is the paints and varnish, as I was saying, chemicals. So exposure to chemicals, and yes, particularly woodworking, leatherworking, the tanning industry. There is data out to say that exposure to these kinds of things leads to increase in cancers of the paranasal sinuses.
Right. And also some radiation exposure. There are certain cancers which are also induced by radiation exposures.
Yes, yes, of course. But particularly thyroid cancer is the one that is presumed as susceptible to radiation.
Does head and neck cancer have any association in running in families and
So compared to other cancers, I mean, particularly genetics has been greatly talked about with regard to cancer of the breast, because we have worked out on the genes which cause it. But when it comes to head and neck cancers, genetics are not yet a major focus, not yet the major cause of head and neck cancers. It's mainly environmental with head and neck cancers.
Okay, right. But please tell our listeners, what are the various warning signs and symptoms? What should they be watchful about?
So head and neck cancers is a huge group, and this includes oral cancer, mouth cancer. This includes cancers behind the mouth, which are the pharynx cancers. This includes cancer of the voice box, which is the larynx. This includes cancers which then sort of spread to the neck. They occur inside the throat or in your swallowing or breathing tube and then spread to the neck. So you can have neck problems. And of course, there's the nose, and there is the area behind the nose, which we call the nasopharynx, and there are the ears. And there is also thyroid cancer, which is on the periphery of head and neck cancer. So what are the areas you should watch out for? For mouth cancer, if you have an ulcer, especially an ulcer which is painless, and especially an ulcer which has lasted more than 6-8 weeks, you need to be very careful. So any persistent ulcer, especially if it's painless, for your throat or your pharynx or your swallowing tube cancers, if you have difficulty in swallowing, if you have pain in swallowing, if you have hoarseness, if you have breathing difficulty, if you have obstruction to swallowing, then that indicates that something wrong is happening there. And again, if it has persisted for more than 4 or 5 weeks, you need to get very careful. If you have a lump in your neck, then that may indicate that there's a cancer which is spreading to the neck. Indicate to a thyroid cancer, it may indicate to a cancer of the salivary glands or the parotid gland. And these are the usual causes of cancer. From your nose point of view, if you have persistent bleeding and obstruction, if something has persisted beyond 4 weeks, I think it is time for anyone to seek medical treatment.
Warning signs, if they are persisting for a couple of weeks, that's when the patient should be alerted and should look for a right physician or a clinician to be examined. But you've mentioned so many subsites in the head and neck area. A lot of patients keep comparing themselves with each other, But do the various subsites have the same biological behavior? If I compare oral cancer with a thyroid or a salivary gland cancer with a nasal cancer, are they biologically, behaviorally different?
I mean, these are all very different cancers. So certainly a thyroid cancer is generally a cancer which we tend to look at in a more favorable way because they generally are slow growing. Similarly, cancers of the salivary glands may not be very aggressive, but cancers of the oral cavity are generally aggressive. Cancers of the voice box or the larynx may not be. But you see, there is going to be so much individual variation. It's a
Correct.
difficult diagnosis. It's a diagnosis which has potential to be aggressive, and every patient with such an illness should not look at ignoring these symptoms.
Right. So, how are these patients investigated? What are the various battery of investigations that we ask them to undergo?
One thing that everybody needs to go through to confirm a diagnosis of cancer is a biopsy. A biopsy is a piece of tissue that is sampled from wherever the physician suspects that things may be going wrong. And that is number one. That is confirmatory for the problem. Our next step is to consider as to whether this is an illness which is localized or whether it has spread elsewhere. And for this, we tend to do scans. These scans may be ultrasound scans, maybe CT scans, maybe PET scans. And thirdly, there is what we call as endoscopy, which is that we sort of look inside to map out the exact limits of the cancer that we are looking at. And this is really basic evaluation before one moves forward to decide on treatments. Treatments are today generally preferred to be made in multidisciplinary settings. By that, what we mean is that we work in teams, and teams generally include some of us who are surgeons. It includes some of colleagues who are radiation oncologists who give radiotherapy, radiation therapy, and it includes colleagues who are medical oncologists who give chemotherapy treatments. And as things have expanded, this also includes pathologists who have expertise in actually trying to discern as to what treatments may be appropriate for which patient and the kind of cancers we are dealing with. So really, there are many, many people who get involved with such decision making.
Correct. So how do we treat these cancers?
So as you alluded, these cancers are all quite different from each other. Mouth cancer is a little bit different from pharyngeal cancer, is a little bit different from voice box, is different from thyroid. There are cancers which are best treated by surgery, and that generally includes voice cancers. It may include some patients with a voice box or a larynx cancer, wherein you could use a laser with very little morbidity. It includes a lot of patients with thyroid cancer. And there are other patients who are better treated with radiation therapy. This may include patients who have pharynx cancer or oropharyngeal cancer. So different cancers, depending on their stage and depending on the extent that they has progressed and the site, are treated a little bit differently, but it is generally a combination of surgery, radiation, and chemotherapy.
Right.
And not everybody needs to have all treatments. In fact, patients with early cancers generally will have only one treatment. Patients with advanced cancers may need more than one treatment.
Correct. But Dr. Alok, is it true and correct to say that the treatment of head and neck cancers carries its own functional morbidity? Because people are often scared. One is the cosmesis and the other is functional morbidities that they have to undergo.
This is true, unfortunately. All of us tend to take things for granted till you're sort of faced with the prospect of things not working well. And certainly breathing, speaking, swallowing are something that are taken so much for granted.
Right.
Unfortunately, any illness in this part of the human anatomy is bound to impact all of these things. But the good news is that things are so much better than they used to be. And there are lots of reasons for it. Part of the reason is that we have radiology and scans, which allow us to really localize where we need to work and which area needs to be focused on for either surgery or radiation or whichever. Then there are so many non-invasive or focused ways of both operating and giving radiation. So today, surgery is often done in a minimally invasive way by either lasers or robots or other techniques that have become available. Radiation is also given in very focused ways by newer techniques that we tend to call as intensity modulated radiation therapy, IMRT. And even in terms of chemotherapy, we have targeted treatments. So there is no doubt that medicine has moved forward so much to limit much of this disability.
So, but
There is no doubt that medicine has shown such dramatic, life-changing, life-preserving advances over the years. So I alluded to the use of lasers, which is it's a very precise way of doing surgery. There are robots which allow you massive magnification. There are extra ways of looking, what we call infrared ways, so that when we do surgery on the thyroid, we can preserve some structures which we call parathyroid so much better. And also with terms of surgical techniques, we have moved on to a situation wherein we can reconstruct tissues by taking a bit of a bone from the leg or a bit of a skin from the leg or from the arm and transplanting it into the mouth, and what we call as microvascular reconstruction. So technology has undoubtedly been a major driver of improvements that we have seen in medical care over the past couple of decades. Very much so.
Beautiful, sir. You talked about precision medicine in cancer care. Lately, we've been talking a lot about molecular profiling and DNA genotyping. Can you just tell our listeners what is this all about and how has it been able to make a difference in the treatment that we are offering? What answers have we got through by doing these high technology research oriented techniques?
Cancer is ultimately a cell which is abnormal, which doesn't quite know when to stop replicating. In simple words, that's what a cancer is. It just goes on and on and on and keeps on replicating. And over the years, we have been able to decipher as to what is it in this cell that is driving this. So the Human Genome Project, which was there 20 odd years ago, was really, I would say, a very ambitious proposal at that moment in time, wherein we wanted to look at every gene in the body and sort of map out the entire genetic code of people. But that has now become a reality. And now cancers are being assessed through their genes, and we are slowly finding out as to which genes are abnormal and which genes are associated with different kinds of behaviors. We have found new, very focused drugs which work only on these genetic. I mean, I will take the analogy of what happened with bacteriology or pus culture or infections 100 years ago. There was a time when every infection was treated by either a surgical operation or a single antibiotic. But now we know which antibiotic to use for which organism. And slowly we're coming to the stage for cancer. We can be more focused on what medicines to use. If we use less medicines, focused medicines, we naturally cut down on toxicity.
But with all these advancements, with so much of research going, have we made any difference in the survival figures? And the second is, have we given them a better quality of life?
So the second question is easier to answer. I mean, there is no doubt on that. I just alluded to how treatments have become so much more specific and focused. And so we cause far less damage to remaining tissue than we used to. There's no doubt that quality of life, reconstruction, preservation of function has improved dramatically over the last 3-4 decades. Survival has improved. It takes a little bit longer to show or to demonstrate it statistically, but I would say there's no doubt that survival too has improved. It has improved for two reasons. Treatment is better, and also it has improved because as society gets more developed in terms of its human development and gets more educated, then we see patients at earlier stages of disease than we saw before. So yes, there's been progress. There's been dramatic progress.
When we look at these patients in their follow-ups, do we really emphasize on the need to have a regular checkup and they should be on a constant surveillance throughout their lives?
Patients stay on surveillance. And of course, there are many situations wherein we are very, very confident that patients once treated are not likely to have the problem come back again. Nevertheless, we like to keep an eye on them. And there are other situations where you're a little bit more worried because they've had advanced disease or because of some other factors that may have come through on their treatments. And I mean, every patient, at least for a period of 4 or 5 years, does stay on very regular review and surveillance after the diagnosis.
But do we have any tests to predict failures in patients? I mean, before they manifest any signs and symptoms, can we tell that this patient can have a failure?
So there are some high-risk situations which really are very professional situations wherein we are more careful. That can depend on pathology. There are certain situations, as you alluded, wherein there is ongoing exposure. So if there's ongoing exposure to the carcinogen or the pathogen, then of course that's a high-risk situation. Tests are available. I mean, there's been a huge surge. So as you're aware, the PET scan, which really came into its own some 15, 20 years ago and is now so standard for treatment, is a test which helps you pick up recurrent or early cancer much before it may actually manifest or show itself up clinically. And these are tests which are used in the when you care and follow up for these patients.
Are there some tumor markers which will help us pick the patient early?
So we were talking about cancers which are caused by viruses. And we alluded to the oropharyngeal cancer, but there is also the nasopharyngeal cancer, which is caused by another virus, the EB virus. And sometimes we're keeping an eye on how the EB virus antibodies are in the body. We can detect an early cancer coming up. Unfortunately, in head and neck cancers, there are very limited options for blood tests which can actually pick up. But yes, nasopharyngeal cancer is one wherein we tend to use EBV DNA, as we call, to try and certain if there is any change.
I feel head and neck cancers are highly preventable. So what are the preventive measures that we must tell our listeners to prevent this cancer?
So I would totally agree with you that there are cancers which are basically predisposed because of the genes or hereditary that we are born with, and there are cancers which occur because of the environmental exposure, and head and neck cancer in general are environmentally induced. Two major causes, of course, are tobacco, alcohol, betel nut, these kind of exposures, and maybe the HPV virus infection for the oropharynx cancer. So sensible living with avoidance of alcohol and tobacco, avoidance of betel nut would certainly go a long way in keeping you safe from these kinds of cancers. There is also the issue of HPV infection. Promiscuous sexual activity can lead to the spread of HPV cancers. And again, this is something that we need to be careful about. And sexual activity may not be promiscuous and certainly should not be unprotected.
Right. So we're almost to the end of this program, Dr. Alok. Is there some strong message that you want to give to our listeners?
Well, I would say that our listeners being aware of the damage they do to themselves is very important. So awareness with regard to tobacco use, alcohol use, supari use is essential. And certainly your program is in many ways the way that this awareness is going to spread. So I would say to everybody to really be careful, not only with your own selves, but also with others in your community. If there are others who have these kinds of vices, as you call them, then they should be avoided. And there is help available nowadays to help people to so-called de-addict themselves from both tobacco, alcohol.
Thank you. Thank you so much, Dr. Thakkar. It was wonderful talking to you. And thanks for such valuable and beautiful pieces of information that you have shared with our audience. Sometimes our struggles in life turn into our greatest strengths. These tough times enable us to grow into individuals that we must become. But when we are continuously being battered by the storms of life, all that we need to do is to hang on to faith. And that's one support which can weather any storm. Thank you once again, and thank you to all the listeners. See you next week in another episode. Till then, goodbye.